in the database. From the hospital perspective, we do collect some information, but this is primarily an EMS intervention, and so the lift on the hospitals is fairly low. We ask a minimum of up to 5 questions, and for many of these cases, this spot over here in the top left corner for ER outcome may be that the person died in the ED and then the record's completed from the hospital side. We're interested in bringing CARES into New York City, and we have this potential timeline for which we can do it. We'll start in the first quarter by onboarding agencies and hospitals and their systems in one borough, sort of to show that we can do this and we can collect the information and complete the records. At the end of the first quarter, we'll begin unloading the next section of a borough or 2 boroughs so that we can continue this rollout in a way that makes sense for your needs, as well as adding people to the registry in ways that make sense for theirs. By the end of 2023, our goal is to have all New York City agencies and hospitals and hospital systems participating in CARES so we can begin 1 full year of data collection for all participating agencies and hospitals in 2024. Here's how this can work. From the New York City side, we'll have somebody who's able to be the New York City CARES coordinator and hopefully a committee of folks who are able to help us bring this through at the local level. From the state side, we have the state coordinator site based at University of Buffalo with Dr. Clemency, Bridget, and myself. And then there's the CARES national team that's based in Emory University in Georgia, and Dr. McNally and his team are committed to bringing everybody on as seamlessly as possible. We do have some resources available to be helpful. First, we have the ability for ePCRs to be uploaded to CARES directly. There is a partnership with one of the vendors that is prominent in New York City, Health EMS as we understand it, and that can be uploaded into the database so that someone isn't manually completing the worksheet for every cardiac arrest. The American Red Cross has also agreed to fund a coordinator for the New York City part of the New York State CARES and National CARES program. And then we have our team in Buffalo, and we will do whatever we can to be helpful to make this a success. We have lots of experience in bringing on agencies, and this is something that we're hoping to help you all do as well. Are there any questions?
I have a quick data question.
Mm-hmm.
So this is all de-identified data, or is it patient information, like each individual record, or is it an aggregate? How is it uploaded? And do you need permission from the family to share, if it's identified data?
So I think I heard about a third of the echo, so I'll do my best to answer. And if I don't answer everything you need, please let me know at the end. So no, you do not need patient level permission to do this. This is a public health registry that also has IRB approval as such. The reason you do need PHI is to link to the hospital record. So you need to be able to tell the hospital who the patient was so that the hospital is able to find the patient. Once the patient's outcome data is linked, all identifiers are stripped. And so the final version after the annual data set is cleaned has only clinical information, and all of the PHI has been washed. One of the ways I think this is also helpful is, traditional outcome data between hospitals is, emails and trying to ask, hey, can you look this case up and what happened in this case? CARES provides a single clean, HIPAA secure interface for all of this to go by. And so it's easily scalable between multiple hospitals and multiple EMS agencies. The hospital may not even be aware of which EMS agency the case is coming from readily, because it's all being pushed to a single hospital or single hospital system. I hope that answers your question.
It does. I guess the question also is, there's 72 hospitals in the 5 boroughs. If you don't have full participation, I guess you wash out those patients, so you don't have a hospital data point.
Yeah, so our goal is to obviously have full participation. We have found that the biggest success comes not from targeting individual hospitals, but rather hospital systems, right? Typically, large STEMI programs or other large registries are based out of a mothership for a larger system. And we have found that managing the registry with a smaller number of hospital systems is much more efficient than a large number of individual hospitals. Do we need every single hospital on board to flip the switch on day one? No. But the goal is to, throughout 2023, make all those connections so that we are able to go in, hopefully 2024, with the entire city represented.
Is there any cost for any parties?
There is no cost at this time to anyone who is participating. The American Red Cross has offered to fund a coordinator to take care of New York City. Obviously, the scale of New York City is such that the Buffalo operation, who's covering the rest of the state, would be subsumed by the volume coming out of New York City. And so the plan is to have a coordinator specifically taking care of New York City, who then can get other resources from the statewide coordinator in Buffalo. There are because we're a statewide registry system, individual EMS agencies do not need to pay to come on. If you looked at the national map where there were individual circles in some of the white states, those are areas where there's not a statewide initiative and individual agencies are paying. But that would not be the case in New York State, and hospitals never pay in the CARES model in any state.
One last request, you could just share the presentation with the members of this committee.
The question was, can we share the presentation? Absolutely. We can email that. Now, I just want to be clear, the timeline in the presentation is one proposed timeline. And part of why we're talking to the regional, the REMAC today is to try to better understand what is the best way to go about this. If you guys may, or gals may have suggestions, better ways to do it, New York City better than we do. And so I don't want us to get too caught up in any one single implementation plan. The best plan is the plan that you guys think is the best option.
Yep. And I couldn't agree more with Brian's statement. I'll just add to that, we've had experience implementing in many other cities. Obviously, New York City would be the largest, but most recently, LA County. I think the economy of scale, just to remind folks, right, almost all of the MS data is coming in through Health EMS, which makes things a lot simpler for the MS piece of the equation. From the hospital, right, there are 70 plus hospitals, as you mentioned, that's correct. 6 large systems, and we've had some outreach. There's great interest, in those large systems already, a lot of which are also obviously voluntary providers. So they obviously manage patients in both environments. So I think that's exactly why I wanted to have this call was, a lot of conversations over the years have led up to when is the right time. This seems to be the best group to present to. That's the message that we've gotten back, and we really want to listen carefully from the folks in the room to advice you might have. But I think the answer is we would do this logically, borough at a time, or over the course of the year, have a lead. 12 months to do this, we think is reasonable, but it really would benefit us to learn from the folks in the room and the conversations that happen thereafter. This idea of an implementation committee, we think, is a good opportunity to help us make this even more efficient.
Who is selecting or making contact with the hospital-based data person for CARES? Is that selection coming from your office, or is that something that we would have to do?
The court, well, a great question. There's already been conversations, myself included, Brian. We've met with many systems that are represented in your meeting today already to kind of give them some background about CARES. The message back was this would be the right audience to present to. But I think there's enough critical mass of interest in terms of both from FDNY, from the voluntary hospital systems that are providing the majority of EMS care, and the respective hospitals. So like personally, I've talked to, and Brian, as well as Susie, talked to all 6 of the largest health systems, including most recently HHC. So there's been a lot of legwork leading up to this, but, and that's what we've learned in other cities is you have to have, a critical mass of interest to be able to say, okay, you can't wait for every single hospital, like Brian said, to be ready. But that's why we would use a year to onboard this and start, in a borough that's going to make most sense to get started and show proof of concept. But the good news is, from a logistics standpoint, it's essentially one large vendor or one health EMS is where the records are going to come in, and then 6 of the large health systems will be the vast majority of hospital outcomes. There'll be the other single hospital system or single hospitals that will need to onboard. But historically, in a large community, if you get the big players, the others will follow. And it's sort of a soft peer pressure model, I guess would be the nicest way to say it.
Thank you.
Any other questions? All right. Thank you guys very much for this presentation, and we look forward to the next steps. We'll do some
So Joe, it would be our hope that the REMAC REMSCO would identify a handful of EMS leaders to kind of serve as an advisory board or an implementation task force to help next steps. We could work closely with them over the coming weeks and months and then report back to this group based on progress and next steps.
All right, we will work on that on our end.
Thank you very much.
Thank you. Have a great meeting. Thank you.
Very much.
Have a nice meeting.
I'm gonna fall asleep though. All right, is there any additional discussion on the presentation that we just saw?
That's right. It just seems like they're only using health EMS, right?
That's what they're starting with. I think their thought is that if they use health EMS, that the smaller agencies will come on board as well.
Seems like the smaller agencies have to do a manual upload of the card.
That's really a challenge. I think that there's a lot of next steps that we don't all have right here, right now. So I think that we do need to have some kind of CARES implementation tag. I think there's 2 components to this. Obviously, there's a QA component. Eventually, there might be a research component. I think those need to be, when we get to the final product, if we choose to implement this, those will have to be kept separately because QA is protected under HIPAA and it's required by the region. But there should be a separate process for research projects and how to process that or how to get it through the system in terms of IRB approval, in terms of how data gets shared and so on. I think that I would love to see interest from this group if there's anybody here who is interested in participating in a tag for the CARES implementation. Please let us know. I see Matt, I see Jess. Who else? Anybody?
So I'd be interested. I think also from the quality perspective, it's probably useful.
I think that, like I said, I think that eventually part of it will fall under the auspices of quality as a separate entity. It sounds like from an implementation perspective, how they're going to implement, what resources they need from our region, that's more global than QA committee. And I think that putting that burden on the QA committee is too much. But eventually, once we're at the point of implementation, the quality component will be a QA initiative, and the research component will be a research component where people can submit, queries for research or queries for data to our region for review. But I think that the first step is an implementation group that will kind of go over what is needed to implement this in the region.
As it pertains to the 911 system, the majority of our participating partners are on Health EMS, with the exception of one small third-party contractor in the Bronx. So Health EMS-wise, it'll be an easy lift, 911 related.
Great. Okay, so I saw Matt, I saw Jess, anybody, Doug, Pam, Michael? Is that what we got so far? All right, so that's a great start. Okay, Emery. Anybody who else wants, David? Great. Please let us know. All right, so if, we will definitely get that started. We'll have a chair for that committee and we'll go forward with the implementation. Okay, any other questions about the CARES presentation? Okay, hearing none, let's move to the REMAC meeting officially. So do you want to do, since want to do a roll call, or how do you want to do this? Do you have to, or you want to center around the minutes?
We don't have to do a roll call, we did that, you know what, we can do roll call if you want.
Just make sure we have a quorum.
Yeah.
I think that's a good idea. And then we'll move forward to.
Want to call your name, please, say present. Grace Cacciola, present. Dr. Seda?
Here.
Dr. Kaufman?
Here.
Dr. Gonzalez? Dr. Reisman?
Here.
Dr. Lai?
Here.
Dr. Isaacs?
Here.
Kevin Ward?
Here.
Henry Dugenti? Samia McEachin? Jeffrey Rigrich?
Here.
Reed Caldwell? Dr. Jonathan Berkowitz? Dr. Marshall?
Here.
Dr. Redlener?
Here.
Dominic Bettinelli? Ethan Rendon? Dr. Schenker?
Here.
Michael Vatch? Robert Ackerman?
Today.
Dr. Bowe? Sean Graves?
Here.
Dr. Winchell?
Here.
Dr. Jarvis? Dr. Cantor?
Here.
Dr. Krupe?
Here.
Mary Foote? Timothy Stiles? Dr. Ivacoli? Dr. Kessler? Dr. Fink? Dr. Carter? Eric Cohen? Dr. Manjal? Dr. Vespalos? Here. Dr. Smalls Nancy? Dr. Harris?
Here.
Dr. Van Voorhees? Here. Dr. Zabar?
I gotta leave early, just make sure you have a quorum without me.
Dr. Barber?
Present.
Long one to listen.
Dr. Benelli?
Good husband.
Right here. Right.
Dr. Langsam?
Present.
Anthony Shalish?
Yeah.
Okay, next I'd like to move to approve the minutes of the September 13th meeting. The minutes were emailed out. Is there any questions about the minutes, concerns, comments? Anybody who's listed as here who wasn't, or wasn't who's here? All right, hearing none, can I get a motion to approve? So moved. All right, excellent.
We're recording, and last time we recorded our meeting, some people speak softly. Speak like you're in your ER, loud, so that we can pick you up on recording.
All right, correspondence report, Marie. Seconded a motion. So I guess there was a motion to approve the minutes. All in favor?
All right.
There you go. Is that better? You happy?
Yes.
No problem. No problem. We're here for you. All right. Marie, the correspondence report. So we're good. Oh, this one.
Can't do it without you. Okay, correspondence report. Emails were received from the following who are unable to attend tonight: Peter Wire, David Battinelli, Arthur Cooper, and Nick Alexandru. An email from Peter Diorio, Director of Pre-Hospital Care, appointing John Vega, MD, as a replacement for Lauren Costurco, and we received a copy of his CV. Stroke designation letters from Bellevue Hospital, which was designated a comprehensive stroke center, and Phelps Memorial Hospital, which was designated a thrombectomy capable center. I don't know.
Phelps is like up in Westchester. If any of us ever taking the thrombectomy patients over there.
Terrytown, you may want to go to Terrytown.
Peter Diorio, who's the Director of Pre-Hospital Care at Jamaica
Okay,
Hospital.
so stop. That doesn't matter. Lauren is a Greater New York Hospital Association appointee, so it would have to come from Greater New York. That's irrelevant.
Okay. We will double check on that.
Yes, it is. Westchester Medical Center is also a stroke center.
Yeah, I don't know why we received
It's
that.
fine, whatever.
Do we ever send
We never
ambulances
send
out?
patients there,
No, but I
I
think they
send a notice out.
Okay, and we received an announcement from Bureau of EMS about an adult care facility presentation that was given on November 1st. You're going to have things here that are older because we got them right after the last meeting. And everything that we announced has already been distributed region-wide. We have an EMS passenger restraining devices policy from BEMSATS, polio vaccination training requirements. We have obviously the outbreak of Ebola virus information that was sent out again. Bureau of EMS has 2 job openings. One of them is here in New York City. Okay, I'm going to go right to enforcements. Andrew Kenberer, he's from Poughkeepsie, EMT 479267, and he certification suspended for 1 year for violations of Part 800. Suspension is stayed, placed on probation for 3 years. Will Davis, who's from Astoria, New York, EMT 450803, he surrendered his certification. Mike Raiola from Midwood Ambulance requested information on how motor vehicle operators participate in the New York State Healthcare and Mental Hygiene Worker Bonus Program. We're going to be looking into that to see if they qualify. There are 2 pages worth of CME and the types of training that was sent to us and that was sent out to everyone in the region. Paul Barber informed Regional Counsel that Staten Island University Hospital is no longer an active online medical control facility.
That's from the end of this year. That was correct.
I'm sorry?
It will be at the end of the year.
12/31/20.
Oh, so this is, it's effective when? The end of the year?
New Year's Eve, ball drop.
Okay. And that's something we need to talk about. We need more medical control, online medical control.
We're replacing it with a facility at Norfolk.
You are? Oh.
Yes, there'll be a new facility that's going to emerge from the ashes as a phoenix at Norfolk.
Okay, that's actually really good
Put
to
that on
know.
record like that.
Will they cover all local hospitals?
What's that?
They cover all local hospitals.
It covers. Yeah, looks like it is that. And FDA watch alert on a recall on sodium bicarbonate injection. And also, the date has passed, but this was requesting applications for appointments to the National Emergency Medical Services Advisory Committee. And I know that I wrote one letter of support for one of our members. I hope more people put in their name. And we sent out agendas, minutes, associated attachments for the meeting. We distributed 2 advisories, 2022-05 New York City paramedic re-credentialing, and 2022-06 protocol revisions. And we are working on the new protocol revisions training package. We also sent out the national guideline for field triage of injured patients and revised dependency, and that's trauma-centered transport criteria. And the full correspondence report will be in the minutes.
Thank you. Any questions on the correspondence? Okay, hearing none. The executive committee did meet briefly via email correspondence to discuss the upcoming protocols that are going to be discussed. The feeling of the executive committee is that some of the changes that are coming up today are more housekeeping changes and do not require CMAC approval. If during discussion there's any questions about that, please bring it up. If anybody feels differently, that definitely should be discussed. And the other thing we discussed was that regional faculty, people who teach the online medical control physician course and do it consistently, will be granted a waiver on their REMAC physician card fee as a bonus for giving these courses and participating. For those of you who are regional faculty, we will let you know. For those of you who are not or are interested, please contact either myself or Paul, and we will give you a rundown on what is needed. Okay, any questions on either of those points? All right, hearing none, let's begin with our subcommittee reports. CNC, Dr. Barbara.
Okay. Serving patient credentialing committee is actually going to be meeting at the end of the week, so our last meeting was sometime in October. Major changes that were submitted for the last medical standards meeting was, as Dr. Schenker had mentioned, the housekeeping with regards to workflow entrance to medical control physician as well as medical control faculty. With the specification of creation of OMC faculty instructor with criteria, as Dr. Schenker had mentioned. There's also some housekeeping to clarify required documents for submission to be either a REMAC online medical control physician or a REMAC telemedicine physician with documents that are sent in support. With regards to paramedic credentialing, which is Ward, report. Paramedic credentialing continues as is scheduled, and it's our hope, actually no, it's our plan that the new year will demonstrate a change to the credentialing process, including the abolishment of the entrance exam as a means of recertification with a CME-based renewal hosted through the REMAC learning management system. There's a small group of myself, Mr. Chang, Mr. Lax, and some other people who I'm going to forget, like an Oscar speech here, that are helping. But the goal is that January 1, the regional updates and CME-based refresher will replace the exam as being the arbiter of a standard of knowledge in the region. It's our expectation that the number of hours may need to be modified based on these changes, but this is better for the growth of our paramedics in the region. Thank you.
Any questions for Dr. Barbara?
Or Mr. Ward.
Or Mr. Ward.
So you can take it.
All right, hearing none, let's move to medical standards. Dr. Benelli.
So, medical standards met about 2 weeks ago.
I'm sorry, Dave, can I interrupt for 1 second?
Yeah.
So we all know that we've moved medical standards now to a 2 to 4 on every other Tuesday. How has that been for people? We were wondering, I know that some people were concerned that they wouldn't be able to make the meeting. I know that the last meeting had pretty good representation. There was, I think, 30 people on the call. Is that a time and date that works for everybody? I'm just putting that out there as a question.
I know that some people approached me and said that they'll never be able to make this time.
Okay.
Not good. So, I'm happy to entertain other times. It doesn't have to be 2 to 4.
Okay.
It's difficult during the workday that early sometimes.
Is there a better time? Would people prefer that be a later time?
2 to would 5 be better? I mean, I don't care, 4 to 6.
4 o'clock would be better.
Yeah,
2
4
to
to
4 is just, again, it's hard to predict what
I think
meetings
4 to
come up
6
that
at least,
they-
people can get
ones
through most of their
that are
day.
scheduled,
Okay. Does that sound reasonable?
3 to 5 maybe?
Maybe we should go back to the way it was and have medical standards for that.
Again, I think that there's a lot that goes on in medical standards lately, and that might.
At least I know one of those surveys.
Yeah.
All right, that's a good idea. Survey.
All right, so we will survey the idea of either moving it back to before REMAC or moving it to a later time on the other, on the
That
off.
survey should be
I think-
anonymous.
No, I think we already discussed the fact that we should have medical standards a couple of weeks before we met, because that allows us to make changes and to have discussions and to send out documents. So I think that should not be an item for the discussion. The item for discussion should be the time.
I think that there's good to have that space, but if the committee feels differently, then we should know that. So we'll send out a survey, we'll include all the questions, including the time, and all the information. All right.
Let me look at the survey before we send it out.
No.
All right, let's move to the report.
Okay. So medical standards met 2 weeks ago virtually. I'm sorry, I'm soft-spoken at baseline, so I'll try to raise my voice. Okay. So we'll go through the action items. So the protocol committee met and brought a number of protocols to be reviewed. I'm going to ask Dr. Lai, are you connected to the projector? Or do we have the Charlie, can we turn the make the projector work? Oh, here we go. Okay, perfect. Thank you. And so I'll let Dr. Lai present the items that are being brought as second in motion to medical standards for approval.
Great, so the first protocol that came for discussion is a modification to the procedural sedation and sedation for advanced airway management protocol. So this, the current version that you are seeing does reflect already the changes that have been approved for 2023. So just the things that are in the track changes are ones that are just for discussion for today. So as you can see, so what we have discussed in the protocol committee meeting as well as for medical standards is that our current use of benzodiazepines as induction. It was felt previously that currently now, even with shortages, we do have 2 reasonable options for paramedics to use, that is etomidate and ketamine, and that with the addition of ketamine here for the as an option for an induction agent, it should be time that we truly should be removing the benzodiazepines in the induction category. So it was proposed to keep option A, etomidate, option B, ketamine for use as the induction agent for sedation for advanced airway management.
Okay, any
Is there
discussion
any
on this
questions on
protocol?
that?
I make a motion that we approve them all in block unless we do a roll call.
I don't think we.
So we're actually only just discussing the procedural sedation protocol as well as the FDY rescue panel.
Okay.
So we unfortunately can't do that because protocols have to be approved individually. Anything that affects patient care in New York City has to be approved individually.
Motion withdrawn.
Okay, any further discussion on these changes to the sedation protocol? Yes, sir.
I have a question about, there's many shortages of medications recently, and I think that it's always good to have another option if it's not ideal. So I don't necessarily think that removing these medications would be a good idea.
Okay, one at a time. Doug,
Benzos, as induction agent, and we're just trying to push best practice, nothing wrong as a medical option or not a medical option as a discretionary order. If there's a shortage, or if there's a simply shortage, that we could come out meeting, but we really want to push best practices. there are options now that will also, I would say discretionary order. So, okay.
And I think that in an event where we're short both of etomidate and ketamine, I think this committee can convene and authorize some emergency.
You also just consider any fentanyl.
Okay, any other discussion on these changes? All right, hearing none. I don't think fentanyl traditionally is an induction agent.
Right, to get the medical. I want to just bring it to protocol. Yeah, right. Bring it to protocol. I think that's another reasonable. I don't think anybody opposed to it. So any further discussion on this protocol? I guess we have to do a roll call.
Yes. So we would have to do a roll call vote for this.
To approve the procedural sedation.
As is, correct? Okay. As it appears on the screen in front of you.
But it was also emailed out to everyone. Can you make it any bigger?
If you make it page view, yeah, that'd be perfect.
Are we ready?
Yes.
Okay. So please respond in favor, oppose, or abstain. Glenn Esteta? Brad Kaufman?
In favor.
Dario Gonzalez? Nathan Reisman? Pam Lai? In favor. Nick Alexandru? Doug Isaacs? Jeff Braybridge?
In favor.
Reed Caldwell?
In favor.
Louis Marshall?
Yeah, I'm thinking.
Okay. Michael Redlener?
Opposed.
Opposed? Arthur Cooper? Robert Winchell? Ed Jarvis? Mark Cantor?
In favor.
Robert Krupe?
In favor.
Laura Ivacoli? Stuart Kessler? Matthew Fink? Wallace Carter? Kevin Munjal? Cindy Basilios?
I oppose.
Yes. That makes more fun.
Matthew Harris?
In favor.
I know, I gotta count, that's really tough.
If you had to
Call me.
I'm not gonna do it.
call.
Jessica Van Voorhees?
Yes.
Benjamin Zabar?
In favor.
Paul Barbara?
In favor.
David Benelli?
Affirmative.
Peter Warr is not here. And I did not call the chair. Would you like me to call you now?
Let's see what the number is.
I don't think you have to worry.
Unnecessary unless it's well, we might not hit it.
14, 15, 16, 17. Yeah, 17 is, so this carries.
Thank you.
Joe, does this go to CMAC or when is this?
So, like I said at the beginning, I don't think that removing medications that were already approved needs to go to CMAC. I don't think there's anything that we've done to change our protocol, and this is more housekeeping on our end. So my feeling is it does not. If somebody feels strongly that it does, we will send it up to CMAC, but I don't feel that it does. And I've discussed this with Lou, who chairs medical standards at CMAC, and we're in agreement that it doesn't need
It's
to
not a
go.
substantive change.
So as of right now, January 20.
Well, again, this is not in the protocol bundle. That would be a separate discussion, but I'm sure we will have it at some point tonight. All right, next.
Okay, next protocol.
All right, so the next protocol, there are a lot of minor changes in here? Do you want me just to go through all of the changes and then we vote on them? So this is the FDNY respiratory medical protocol?
Yes, we can do them, we can use the whole protocol in block.
All right, great. So let me make this bigger on my screen. So I'll just go through the changes stepwise as they are encountered through the protocol. For the most part, these are just minor changes that were added on here to these protocols, and I'll go through them. So everything is just highlighted in red, track changes. Under the initial management, we did add nasal capnography monitoring on here as serious conditions permit, just to make this a little bit more clear. This is what our providers currently do. But we just wanted to make this a little bit more clear on our protocols. The other thing that we did change, this was something that was discussed, I think, amongst some of the changes that have been reflected in ATLS, as well as a lot of discussions that we've had with a lot of subject matter experts, including local trauma surgeons, as well as those in the military, to move the systolic blood pressure limit for hypotensive resuscitation to 100 millimeters of mercury, to make this sort of as a blanket change and not to necessarily have that distinction for TBI patients that we previously have done. That is somewhat consistent and more simple for our providers to be able to remember. Hypotensive resuscitation, we did just change this just as a nomenclature, just as it's a little bit more of a common phrase that is used now more in the literature. We did also change our tranexamic acid or TXA dosage. This is in line with what was previously been discussed and approved for the PSU protocols. So this does match their dosing as well as their administration in terms of giving 2 grams IVIO as a bolus over 2 minutes versus the prior dilution over 2 minutes. Nothing has changed with our blood product administration as of yet, but we do anticipate that there will be some changes coming up in the, hopefully in the next, probably in the second quarter of next year. The other thing that we did do in here is for the ultrasound guided examination. We did previously have this, as you'll see further down in our blood administration section, that we did have EFAS as being one of the potential criteria to detect the suspected massive hemorrhage. But we did move this up further, so as purpose of an ultrasound guided examination is available and trained to do so. I know that Doug will touch upon this a little bit later on in a little bit more detail if needed. This next change was just something that we just flipped just in terms of it's the same dosage, same medications, but we just changed the order of them as Cephalosporin is the one that we do prefer our medics to give as a first line antibiotic. The next change was that we did add the use of needle microfibridotomies in our protocols for pediatric patients. This again has been much discussed with Matt Harris as well as a few other pediatric subject matter experts, and then we'll come to that once we get to that airway management section in a little bit more detail. We did just modify the language for our compressive syndrome or crush syndrome protocol for our pediatric patients. This again reflects the language that's in our current REMAC protocols or soon to be REMAC protocols in 2023, where the dosage for dextrose is just given as a weight-based dosage. And then sort of the specific in terms of like what dilution of dextrose to be given has been removed just because of the recent shortages and everything that we have been given. So we just have the same language that we have here that has been in our REMAC protocols, and then we just added a dosing table for our paramedics. We did also just add a dilution in our protocols for our regular insulin, in the cases that we do have to administer this to a pediatric patient, that we would have to dilute the insulin in 9 mLs of normal saline. I think that we did just also add in for these patients as a medical control option or prolonged field care option, just the use of non-invasive external catheters as needed, so that we may not necessarily have to use a Foley catheter for these patients for urine output measurements. This is so for airway management. So again, After talking to our pediatric colleagues, we did remove atropine to be considered to be used for infants when used before as a before induction agent for airway management. That has been consistent with the current recommendations currently in PALS. The other big thing that we did significantly change on here is the use of needle creds for patients. Again, with a lot of discussion, I think, especially with a lot of things in terms like for our pediatric patients, for those as a last resort use is for the needle creds for those patients that cannot ventilate or really manage their airway for any other needs. After discussion with some case intensivists as well as with Matt, we did want to just kind of make this a little bit more consistent as well as realistic in terms of truly, I think that we could have gone a little bit more detail, I think, with the age, but I think just to keep it simple, we could just keep the age limit just as we have just with our regular programs. The other thing that we just did modify just for our sedation protocol is that before that we have on here, as you can see, we did have fentanyl to be used as a medical control option that could be used in conjunction with some of the sedation agents. But since we did move forward with that in our REMAC protocols, especially for the airway management, fentanyl is now a standing order option. So we did remove this as a medical control option for our rescue paramedics to then just include the line that they can consider using additional pain medications for analgesia conjunction with the sedation medications. The next thing in our pain management protocol, this language change, I think it's just as we had discussed during our last REMAC meeting, that we do want to give some discretion for these weight-based dosages for these patients. So we did allow up to for the current weight-based dosing. That's similar to what we're using in our recently approved REMAC general pain management programs. I think just the last few additions that we did add on here is just going to be to our appendices, where we did have, in terms of for the use for our mechanical ventilator, we did add pediatric settings for us. To be used in addition to the current adult settings. And like I said before, we did also add the needle cricothyrotomies on here for the appendix as well. But I think that's a summary of the change. I don't know, Doug, if you want to elaborate on any of the changes that I just brought up.
Yeah, thanks, Ben. This one, I'm going to explain up here. Thanks, Matt, for yourself. One of this is pediatric issues. That is a great help, and also the other subject experts as well. Thank you.
Does anybody have any questions for Doug or Dave?
Again, these are specialty protocol only for rescue paramedics, only in rescue jobs. They're not for the general EMS community. They're very much like the ESU protocols, like the HAZAT protocol. They're for very specific providers and for very specific settings. Any discussion on these protocols?
So, you went kind of quickly. I know the term hypotensive resuscitation you used early on, but I didn't actually see what you said about it.
Well, when we spoke with hypertension, we thought it was kind of a more passive system. Wasn't there? It's why we changed the stop blood pressure. Instead, everything is solid, but it says PI greater than 90, but it's certain experts and so on. Because the literature ranges from 100 and recommendations that we say greater than 100.
Yeah, I guess the only thing I would tell you is I don't think that's hypotensive resuscitation. That's probably the usual terminology. So I think it's fine to pick that number, I think. We wanted to consider a lower number for people with active external hemorrhage. That would be not about it. If you want to keep it simple, I think that's fine. I probably wouldn't classify that as hypertension or hypotension.
Dr. Winchell. Any other comments? All right, hearing none, we will vote on this rescue medic protocol en masse. Most of the changes, the reason that was felt that it doesn't need to go to CMAC is because a lot of it is housekeeping, a lot of it is matching things that have already been approved. Needle crike is something that has been in our protocols before for pediatrics, was removed because in most cases it's not the best option. But in this situation, it could be a necessary option. That was the thought behind not sending this to CMAC. So if there are any opposition to that, please let us know. If not, we can try a roll call vote for these protocols in mass. Hearing none. Let's go.
Okay, so we are voting on the FDNY Rescue Paramedic Protocol with minor changes revisions. Once again, please respond in favor, oppose, or abstain. Glenn Esteta.
In favor.
Bradley Kaufman.
In favor.
Dario Gonzalez.
In favor.
Nathan Reisman.
In favor.
Ham Lai. In favor. Doug Isaac.
Favor.
Jeffrey Raybridge.
In favor.
Reed Caldwell.
In favor.
Louis Marshall.
In favor.
Michael Redlener.
Favor.
Robert Winchell.
In favor.
Robert Krupe.
In favor.
Laura Ivacoli. Wallace Carter. Cindy Basilios.
In favor.
Matt Harris.
In favor.
Jessica Van Voorhees. Benjamin Zabar.
Favor.
Paul Barbara.
In favor.
David Benelli.
Yes.
Unanimous.
Thank you. All right, Dr. Manelli, back to you.
So, I think anything further from the board committee? I think.
No other for the protocols. I'm sure they will probably have a discussion later on in that, just in terms of how do we want to do the rollout in terms of the protocols that have recently been approved during this meeting as well as the last meeting that we had in September.
We'll have that discussion now.
Yeah.
Do you want to just go over the ECMO stuff first?
I want, and this, when you want to go over
We
this.
can do that now, and then.
So why don't we do this, then we'll do the ECMO and, yeah. So, Brad, I guess you want to talk about this, for very nice printouts. Sure.
Brad has a significant pull here, and he was able to get copies of the New York City REMAC medication list printed for everybody. So they have been distributed around the table. They're on the table. You don't get one, but everybody else gets one.
We don't make
So,
copies for anybody.
We don't make copies for most people, but Brad is special.
It's good placement.
but these are $1 a piece.
That makes sense.
Color
Yeah,
and I thought they were.
thanks to Michelle.
No.
All right,
There's one
Brad,
screen
take
per
it away.
person, that's it. One. So this is so there was the medication formulary tag had met and had been meeting, and two of the items that the formulary tag was working on was, one is a medication list that you've seen before in the updated version. The second is a list of those medications that are mandatory to function as either an ALS or BLS ambulance in our system. At the last REMAC meeting, we presented both of those work products, and the feedback was that people prefer to have these merged into one document and provide all that information. And what you have before you today is that product. And so the medication list itself what Ben and I had done is Ben had worked on the list of mandatory meds, and that's, I think, the biggest change here, is that you'll see that after each medication, or some of the medications, there's a letter A or B in red. If it's an A, it means that it's required for ALS ambulances. If it's a B, it's required to function as a BLS ambulance. Now, there are some medications where you have to have one or the other, such as dexamethasone and methylprednisolone.
So if you look at page 6, dexamethasone has an A1 superscript, and on page 6 and page 16, methylprednisolone has an A1, so that's the matching. There's an A2, with 2 of them, there's an A3, so you have to have one of the A1s and one of the A2s and so on. So it's required, but just one or the other.
And that makes it sound a lot more complicated than it is. The idea was to
Look at it.
simplify, and so we think that's very useful to see, well, if it's an A, it has to be carried by ALS units, B by BLS, and A with the superscript means there's a matching medication that one or the other has to be carried. Like I said, one medicine.
Does anybody have any questions on that?
I don't see an A.
Next to the name of the medication.
So if you look at adenosine on the first page, there's an A next to the
It's in
word.
red.
Adenosine.
It's required for ALS, yes.
Oh, you're color.
First don't color, that doesn't mean anything.
Well, you can see A.
I'm still
asking why the benzos don't have
Are you letterblind?
I'm looking at diazepam.
Pretty ableist.
It does not seem to have an A.
Diazepam's not required. So look at the first page, adenosine.
He understands what you're saying. He's saying, why is a benzodiazepine not required for
I thought we
ALS?
said something about if you don't have benzodiazepines, you can't be in service.
So in the current protocol, you need midazolam, because on all the other benzos, you can have one or the other.
So
But
why don't they have
since-
superscripts?
Because midazolam is required, and so if you have midazolam, you don't have to have any of the others.
Wait,
So since
and
midazolam
you
is
don't have
required,
midazolam, I'm very confused. If you don't have midazolam, you have one of the others, you can?
Wait, so let's go over this. You must have midazolam to complete the protocols. So by definition, once you have a benzo, which is midazolam, which you must carry
You have a
to
benzo.
complete, you have a benzo and you are okay. If you choose to have an additional benzo, you can choose it, but it is by choice. But you must have midazolam,
that's why there's
because you
A
need it
next to
for IM,
midazolam,
which you can't use any of the others.
and there is no A next to any of the other benzos.
So midazolam is the critical one. You don't have it, you're out.
Correct.
Under the current protocol.
Until there's a shortage of it, and then we approve a substitution.
Well, there is a shortage of it right now. There's a shortage of also of both of
There's actually a shortage of all of them, but midazolam is still the easiest one to get.
one having supply.
You just have to get it in different,
So, out of the cart.
it's available in different configurations. You have to draw 28 miles.
And I think that's the exact purpose of this list, is to have these discussions, so that we're all on the same page. So that's really actually useful for us.
This document is designed to be a living, breathing document. It is supposed to change as the protocols change, and grow with us. That is how we are trying to put it together. Yes,
So
Paul.
I think it'd be worthwhile to the work that Dr. Zaber and Kaufman did, that the interpretation could be that this is a formulary. I think that should be clarified on the top of this document, saying this is a method of organization for available meds, but is not a requirement, or what's the word I would look for here? But this is not the requisite medications to be. This is not the formula. There's a difference
So,
between this
you
and
said it wasn't on it. So,
No, I said
stop.
this is not a formula.
No, so this document is a medication list. It is a list of every single
resource.
medication, and it tells you which ones are required for ALS, BLS, or can be used for anything.
Yeah, I don't want to have someone read this and say, I'm not compliant with the region because I don't meet all the checkboxes and superscripts and tildes.
But it does say that.
That's what I mean.
That's exactly what it does
That's the
say.
purpose of this document?
This
That's
is a
exactly what it
medication
just says.
list.
They just told me
And if
I'm
it
out-
has
I'm
an
out of
A,
service.
then
They
you
don't have
must-
midazolam.
Dr. Lyson, one
Hold
second.
on. If it has an A, you must carry it to be an ALS unit. If it has a B, you must carry it to be a BLS unit.
So then my corollary is, what's the enforceability of this document? If we're gonna have this document out as a region, what's the enforceability? Are we able to utilize this, or is this an open source reference for agencies to understand to distill the protocols being difficult? I'd like the document to be more useful and not be a regulatory piece.
So it's, again, there was a question, and what formed this tag in the beginning was the question of what is required to be an ALS agency, what is an ALS unit, what is required to be a BLS unit, how do I operate at those levels? This document clarifies what you need to be an ALS unit, what you need to be a BLS unit.
That should go on the top of this list. What you just said should go on the top of this
You
document.
just want a notation on the top as to.
I'm afraid for the document to
superscription-
get weaponized. That's what I'm trying to explain. I mean, it's a lot of work to do to distill down the protocols, but I'm afraid it's going to be weaponized as a regulatory piece, which is not the intent of the document.
Well, I mean, it could, as you say, that doesn't mean that you're required to have everything on.
Yes, it should be a resource, not a requirement.
It's a resource,
So
it tells you what level.
I see it, Ben. You can put your hand up.
Right.
All right, so there is a formulary that will accompany this document, but we wanted to get this out. The formulary will just it exists as a state document. We are updating it with all of the medications that are in our protocols, and it will be a city formulary. That will be a resource document that paramedics can read that talks all about every single medication, indications, contraindications, dosages, all that stuff. But this medication list is the source of truth for whether you need to be a BLS or an ALS
The
unit.
medication reference guide, the fact that you broke it down with protocols makes it very easy to go and find
Correct.
where it would be used.
Ben.
So I don't know what the enforcement is, but my understanding is if you're a unit in this region that's operating under the New York REMAC protocols, you have to be able to do the standing orders. You have to be able to do certain medical control options. So I think, Paul, what you're asking is, if you have an ALS unit in this region and they don't carry adenosine, they can't do our standing orders. I don't know what the enforcement for that is, but I don't think it is any more weaponized than saying, we need not to do standing orders. So you have to have adenosine, is my understanding.
Yeah, so it is in a way, not weaponized, but it is the rules as to what you need to be ALS or BLS. Dr. Lang.
Well, first of all, we don't have our own inspectors, so we don't have people from our organization checking an ambulance to see if they carry all the drugs. And the state is not going to be using this checklist when they come around and do it by them. But the unit shows up on a call without midazolam, to pick an example, and a lawyer then waives this in court and says, did not your region say to you that there's a big A next to midazolam? You had no business being here. Then it is weaponized. I don't say there's anything wrong with it, but that's exactly what this says. It says that in court, we here have said you must have midazolam.
It's the same as if you show up with something that's not on the 800 checklist. You don't have it, like, you're supposed to have it.
You are correct.
Just accountability.
Yes. Anybody? Marie.
Our protocols are approved by CMAC and the New York State Department of Health. So the New York City-based New York State inspectors, when they look at the ambulances, they will look for the medications that we require in our protocols.
In which world did you?
They do that all the time. I get
Mine-
calls from,
I know.
I get calls from the state reps asking me, does this protocol require this medication? Because I'm at this ambulance and they don't have it.
They do. They actually
Well,
do.
in that case, then this is exactly going to serve that enforcement purpose.
That's what we wanted.
Okay, so why are we saying
Doug.
that?
Do we put a disclaimer on top, just as a resource or whatever? Some disclaimer on there? I think it's already written.
A disclaimer.
This is not intended to be used for dosing determination.
That's what I'm saying. That's what it really is.
Yeah. There is, again, this was designed to be a document to tell people what they need to carry and what they don't need, what's BLS, ALS, and so on. That's what it's for. Read.
But I still say thank you to the team and then this, I think it's really helpful. We were recently reviewed by the DOH and this was very helpful. We were working with our calls and figuring out exactly. I am want to talk about another point more and more of we need to make some modifications. Not available every day, what was appropriate substitute without having to decide that.
No, I think that's a good point. And in the event that there is a shortage where something isn't available, I think that the executive committee would say that this is the replacement or this is the appropriate alternative.
Which we usually handle by putting out advisories
Correct.
that people can refer to.
Yes.
And the state has an alternative medication list for just that purpose.
Correct. And the truth is that this document does give you the alternatives in most cases. The only exception to an alternative really is midazolam because you need it for IM. But that's really the only one.
Just have to match up the little numbers.
Correct.
I know we're gonna, I guess, prove it, but just 2 points. One, if you see any, this wasn't just myself and Ben, it was so many people contributed and showing the corrected errors. So any errors should be, kind of nice if you come across something. Because it could be. And the other is that I think what I put very big is 2022 protocol, because this will obviously change. So every time we put out a new protocol version, we have to match this up with the
correct. So the medication list will change as the protocols change. The formulary will include the information for providers to read about everything. And that is in process. Okay.
vote on this?
I don't think we need to vote on it as a roll call vote, but we definitely could take a hands vote to see if everybody approves of that. If that's okay. All in favor of this document, what you see here, please raise your hand. All, I am paying attention. All opposed? Any abstentions? None?
And can I just make one more point? This was sent out to everybody, and
Yes.
feel free to distribute.
Correct.
But it wasn't so pretty.
No, it's definitely prettier in color.
Could you laminate it next time? You think you could laminate it next time?
Michelle could be laminated next time.
$50 a copy.
Michelle is actually turning this into an app. She'll be charging $50 a person.
Oh, she works for Muru now?
Ooh, shots fired. Okay. Dr. Benelli, back to you.
Okay, the next subcommittee, I guess, that has to report is the interfacility committee. I'm not sure John is here. Is John Berkowitz?
John is not here.
So I guess we'll wait for
We're gonna table John's report to the next meeting.
In medical standards, we brought for review. It does not need did not need an official approval for review. The pilot protocol, it has been updated. I'll ask Dr. Lai just to put it up on the screen.
Yes. The ECMO it's not a protocol, it's part of the pilot project, so it's a draft, but it's in the protocol format, so just please understand.
It's not required to vote.
We're not voting on it at all.
It's open just for review, discussion if needed. There are not many changes that have been done to this protocol. We'll get it up on the screen in a minute. The only changes are based on, we've actually met with a couple of the international luminaries pre-hospital ECMO, a guy from Prague, and then we met with Dr. Batros from Boston, and with Dr. What's Chris's last name? No, Chris from New Mexico. I forget his name. Doesn't matter. So anyway, we met with a couple of people, and we were discussing whether or not to include patients with PEA or asystole. And what they unanimously said is that the only important rhythm is the refractory VTAC VFib. Whatever it deteriorates into later on is less important. And they've had successes even with patients that were that deteriorated into asystole, as long as they met the the hospital arrival criteria, lab criteria, of lactic acid, etc., of blood gas, etc. So a lot of them would be excluded based on that, but specifically, what's the most important thing is persistent VTAC VFib at least three checks. So therefore, we removed any wording, if we go down a little bit, and we removed any wording in the exclusion criteria regarding the asystole. I think we should be in favor of that for the simple reason that will increase the pool of candidates that will arrive to these hospitals. As the only other change that is in here was based on a suggestion of Dr. Cooper. If we go down a little further, since we kept this in the format of our regular protocols, medical control, except medical control options, when these are not really options, this just determines what medical control has to do for this. So I removed the word options. So that was a good suggestion of Dr. Cooper, so thank you for that. Other than that, there's really nothing further changing the protocol. Is there any discussion about this? The next steps are going to be now, will be now to send out these protocols to the hospitals that expressed interest in participating. Yes, sir.
I was just wondering if you had a projected start date for pilot.
2023, end of first quarter, beginning of second quarter. We have a lot of training to do. The next steps are going to be sending out this protocol, including request for commitment to the 6 hospitals. We have 6 hospitals that expressed interest. The latest one to join was Lenox Hill, and ask for them to actually commit and say, yes, we're going to join this protocol. It means that their CEO has to sign a letter of commitment, which includes data sharing. It means that they will have to be part of the AHA resuscitation database. There might be some costs of a couple $1,000 for a hospital. Some of the hospitals already are in that database, but we need to have the data available to us. I don't want to repeat previous errors with the prior projects. We need to have the data readily available. And once we have those commitment letters, we're going to start, parallel to that, we're going to start with training, and that has to be a regional training for any provider that can be in Manhattan. We're going to have also discussions with the hospitals that agree to participate regarding the in-hospital protocol. It has to be more or less, at least the first part of it, the receiving, has to be more or less a unified process, and not that hospitals have different approaches. That will not help us with our data, with the validity of our study. So I can imagine that the training is based on our previous experiences with LDO is going to be a huge undertaking for everyone. It will have to be partly on the LMS, on the REMAC LMS. It will have to be on, and probably FDNO will have to do it. First quarter.
These hospitals that are committing, they're agreeing to 24/7 availability.
So that, no, not necessarily. I mean, in the protocol over there, if you look, if you go up a little bit, I left over there in parentheses somewhere a question of a little further. In parentheses, I left over there somewhere in there it says,
times, days of operation.
Yeah, time and days of
Yeah,
operation,
okay,
question mark.
Yeah.
I don't, some places just do it like Monday to Friday, 9 to 4. I'm not.
Will that create an operational challenge for medical
It might
control?
create an operational challenge, but if there's no one to, one thing that all these luminaries in the field emphasize. For Monday to Friday, I'm good enough with that. This is a feasibility project to show that we can do this, and hopefully, getting some people back from these almost 0 we're getting now is going to be encouraging. One other thing interesting that they all said was because this is such a labor, the EMS part of it is only a very small component. They then have weeks in the hospital, partly on ECMO, and then in all the recovery and all that. And they have these survivor clinics, and they bring the hospital survivors to see the successes because it is so labor intense, and that's something that we think how we get our EMS providers involved as well. Something about the future. Yeah.
The participation agreement letters, are they between the fire department and the agencies, or between the REMAC?
It's going to be similar to the LVO. I mean,
Okay.
both Joe and Glenn are going to sign on it.
Okay.
It's going to be very similar to, except it's going to be a very a more, a more strict letter to make sure their participation.
Okay.
Okay,
Yeah.
anything else?
That's the end of the ECMO report. Yes, sir.
Oh, I was gonna make a suggestion.
Go ahead, stand up.
I have a question. The suggestion first.
I appreciate that those aren't medical control options, it's taking away the word options, but I do like, once it's under the purple line, it seems like just taking away the word to make it proof, I would almost move 10 and 11 above the purple line, because they're required, they're not below the purple line.
Just eliminate medical
This
control.
is just, this is a pilot protocol. We left it in the format. I'm sure you could have it changed a million times. I don't think we need to address this right now, and I understand your logic, but we finally succeed to get this project up in the air, and we're trying to decide how we want to write it. I have no problem with that. You know, some would say that, you know, in the LBO protocol, we don't even write the role of all of them, right? So I will leave that for the future.
Just one clarification, we, in the LVO protocol, STEMI, all the other rescue destinations, we don't really do any judgment on the hospital for what they do with the patient afterwards. Meaning that there are PCI centers that don't have backup cabins, there are LVO centers that don't have neuro ICUs. I think it should be known that a huge part of this is going to be coordination of ECMO patients after delivery at potentially another facility within that system or that they have partnership with to reduce quality errors with this type of care. And it's been shown in the literature that ECMO patients should be coordinated at places that do ECMO. You mentioned something about the hospitals. It's really never been our standard to review what the hospitals are doing with the patient afterwards. I think we should stay to that to reduce. Absolutely. I think that's a piece that, you know, we could deal with that in the interfacility tag.
I misspoke.
I think you're talking about an initial protocol.
I misspoke and I didn't elaborate enough on it. Yeah. I'm not going to run that discussion.
Absolutely.
No, I think
the
that
hospitals are going to run that discussion, not me.
Do the luminaries speak to the same kind of concerns?
Listen, I think that is a great point. What we do need to ensure is that whatever standard we expect when we bring a patient there, an assessment of the patient or a initiation
viability for cannulation
in a certain time period,
and a reason
so that because otherwise, you know, to say I'm an ECMO center, but I'm not going to do it except when I want to, doesn't really help us with patients that we're bringing in. So that will be part of the feasibility study when we go through the pilot
And for your
project.
data collection, I mean, we had this experience with hypothermia. We learned a lot from that. Collecting data, hospitals,
And this discussion about how the patients are handled in the protocol is going to be handled by the hospital. Yes. I mean, we're going to bring them to the table, but they would be told that they're going to come up with some sort of unity in how they're going to handle it.
which is important if you want to have meaningful data. Yeah.
But I think that there should be an expectation that is in this letter of participation. Once they've all established what they believe is a fair and reasonable expectation, but whoever should meet, they should meet that expectation. So that should be part of the discussion. Okay, anything else, Dave? Dario.
And knowing all the hours of each.
No. Telemetry knows that. Telemetry, no. It will be across the board. If we decide 9 to 4, if we go back to the protocols, your protocol up there said telemetry will direct it. I mean, telemetry can only direct them from site that's doing it at the time.
So Dario, I think what David is saying in this draft is that we're going to determine what the times are. Everybody will agree to those times before we begin, but telemetry will be involved like with an LVO or a STEMI to say, this is your closest hospital, that's where you're going.
Yeah, they might have to bypass the closest 911 receiving to go to.
I'm only concerned about you calling around.
You're not calling around.
Telemetry doesn't verify.
It's proximity.
That was never going to be the plan.
That's never gonna. It's like we do with LVOs. Nobody calls around.
I just want to know.
Yeah.
That here, it said there, so obviously not gonna verify.
All right, I think this has been a great discussion. I think that Dario is right. There is some fine tuning to do here. I'd like to move forward if that's okay. Is there anything else for medical standards?
No, medical standards.
Okay. Hearing nothing else for medical standards, Dr. Redlener, QA, QI.
The quality committee did not meet this meeting last. It was a smaller group that discussed some details of the AHA data, the quality measure definitions that we hope to bring to the quality committee to discuss an update in order to improve the data that we're seeing. Other than that, we're planning to reschedule the meeting as many members could make the original time. So we'll let you know about that.
Okay, training and education. I know Morty's not here. Joe, can you handle that?
Sure.
Perfect.
So the main projects that the PD committee are working on at the moment is putting together the protocol update training. So I know they just got done over the weekend. They did filming for the video portions of the update training. And they're looking to have that ready for us to upload on our new LMS. So the second big project we're working on is pulling together our new LMS system. It's essentially a collaboration with the State Department of Health, their Vital Science Academy. So we essentially are a part of that now, and we will have our own REMSCO side of that. So for the most part, the end user side, they'll just know they're logged into the REMSCO LMS. But anything that's on the New York State site will, in terms of training courses available, will also be available on our site in addition to any courses that we publish. We're working diligently to try to get all of the users imported from the state site, so most individuals will not have to re-register. They'll just have to answer some additional registration questions on that. We're trying to get the site set up to begin handling the CME-based re-credentialing for REMAC, so that all of the CME hours and everything can be uploaded onto the LMS, tracked by training coordinators. So we'll be sending out information on that in the coming weeks. In particular, we'll be sending out information to agencies requesting who their kind of training administrators are. So we can get them trained up on the LMS, get them access, so that each provider, they'll be able to indicate who their primary agency is. And their training coordinator, as they're uploading their CMEs, their training coordinator will be able to log in and run reports and see all the CMEs the providers are uploading. So I'm sure many agencies have a similar kind of in-house type of program that they may already use. So this might be an option for you for that as well. And it allows us on the region-wide to kind of have some accountability to ensure that people are actually doing the CMEs.
Great,
So,
thank you.
So that's in development, and we'll be sending out some more information.
Thank you, Joe. Okay, Dr. Berkowitz isn't here for the interfacility tag. RTAC?
Please ask questions.
Yeah, I'm sorry, go ahead.
Okay, is the intention that every provider is going to do protocol update prior to the next set of protocols?
So the protocol updates will be available on the new LMS by January 1.
That's going to be regional updates number 1.
But you can't, okay, so it's not required that every provider does that before they use the protocol?
No. This is, from my understanding, please correct me if I'm wrong, this regional update is going to be part of the renewal process.
Yes.
So in order to renew your REMAC, you're not going to take a test, that's what it's for. The protocol update can be done separately by anybody, by any agency or whatever.
And there's going to be a washout period in the middle where people might expire in January, and we want to avoid them taking the test and use the LMS. So getting the protocols up is actually a huge launch, a huge lift by that team. But holding someone out of credentialing due to lack of doing the protocol, that's not the
Right,
way to
no, I
go.
just want to make sure that was the expectation, that everybody's going to do a protocol.
Do you think going forward with LMS being intact and such, whenever we have protocol update right every year, that everybody potentially could go through that? Because retraining everybody for us is a big deal, right? So when we call people with mandatory CME to update, it always takes at least 3 months of lead time. If this system were already in place, we don't have to do it. That'd be awesome for us.
So the answer is that I think from a regional perspective, that is the intent, that everybody can do their protocol update on the LMS.
Including the docs.
The only thing that I think you might have an issue with is union issues with people doing it on their own time, which might be a question for you. But if that's not an issue, then I think that is the purpose of this process going forward, is that protocol updates can be uniform through the LMS, T&E with whatever physician involvement we can get to help develop those training modules, be all through that process. It would help us as a region because we'd be able to track everybody's CME and all their
And be consistent. Quite often, quite honestly, we're paying them 4 hours. We're paying them annual, right? Mandatory or this one. This would then allow us not to have to do something every time.
I agree.
They won't merge it. It's up to call review.
Call review separate.
And still get the deal.
Right, but I mean, if there's updated protocol, you're not putting to the update. I mean, we wouldn't have to, because we take time in that block of time to update. So if we can free that up for anything we need, then that's even better for us. We're paying them anyway.
What my other concern is, to speak on behalf of the group here, of the CNC group, is duplication of education. It'd rather be that these are the regional updates that everyone is going through, as opposed to I went to protocol updates for the region, I went to protocol updates for the fire department or my agency. And that might lead to confusion when there's sometimes a little specificity of a typo, where you'll have two bodies owning the protocol update. The LMS launch is definitely going to be something that can be leveraged as we move forward in the future.
Yeah, I think that's great. The only piece that would always agency would still have to do with any hands-on.
Correct.
Just can't do that. Correct. But that would be awesome. We could cut our time to half, that time to do other things. That would be great. But I know it's going to be a really fun. That's awesome.
Yeah, they'll have the ability to kind of track what the providers are doing. They'll have the ability to upload things on their end. So versus having them, have to bring it into a training coordinator and see that training coordinator person to person, or email it to them. The training coordinator says email and bring the file, and the user will have one profile. And then if they take any training on the LMS, most of that stuff will have bunches of the CMEs on there. We'll be moving the monthly journal CMEs onto that. So it'll be an online training. So no more having the REMAC liaison at the fire department have them get it in by mail, mark you off, get certificate mailed back to you. It'll be on the LMS, they can do it, the provider tracks it, they have instant certification there. All the stuff that LMS. So it'll just be available to everybody in the region and be available for the training coordinators to be able to see see the list of their providers, run report, and see all the CVs that they did.
Just to add on to that with Joe, because I've been on some of these meetings, I urge you to start identifying in your agency whatever training coordinator would be. So it is going to have to be a pyramid of distribution. So, Joe can't reach, 3,000, 4,000 paramedics. There is going to need to be some local coordination. So, and I know who the people are in my agency, I'm sure the ALS coordinators, et cetera, or at BOT, but for those of you with other agencies, it would be ideal to start identifying that training coordinator so that you facilitate that transfer of information on behalf of your providers to maintain their credentials. Whoever that admin paramedic is.
I think that there's gonna have to be some education once the LMS is in place for us to see how it works and what is necessary on our end. All right. Any other questions for Joe? All right. Hearing none. RTAC report. Doug, did you want to do that, or is there anybody that can do that? No.
Just to bring up, because I don't transact here, a lot of countries weren't aware of the trauma guidelines recommendations, so they are reviewing it, and especially the pediatric group, they don't board any suggestions or questions or what have you. So I think the next RTAC meeting we haven't sent out a notice in January. So in the comments, I've spoken to Matt, RTAC, so any comments we'll have in January, and then we'll bring it to here.
Great, thank you.
Just also bring up the letter.
Yes.
Joe.
Yeah. So at the last meeting, I did go to the meeting, and on behalf of REMAC, said to the RTAC that we were very disappointed that this letter came out, a very scathing review that was in no way shared with anybody, no discussion of any kind. They were actually shocked that the letter even went out. They were not aware of it. It did not come out from the RTAC leadership. It came out from the individual who wrote the letter as a draft to every agency in New York City. So I'm a little bit confused as to why that happened, but they were made aware of it and are trying to mitigate the situation on their end as well. Okay. Regional Council did not meet, so there's no update from the Regional Council. CMAC update?
Okay, so CMAC REMSCO met on September 22nd, 2022. There's a lot discussed. I'll try to summarize it if I can. If I got something incorrect, there's going to be also there in Albany, okay, or I should say Troy, okay, feel free to jump in and correct me, okay, or add something they may have left out. So starting with program agency contracts are complete and ready for execution. Tools forms to submit payment vouchers are not complete. This is a problem. New York City, right? New York City representatives of SEMSCO must bring this up for discussion at some of the SEMSCO meetings. The first quarter has been missed, and the end of the second quarter is 30 days away, and New York City is still not completely paid for it this year. So that's a real issue. SEMSCO bylaws tag has been drafted New York State DOH Division of Legal Affairs to ensure all legalities are covered. We hope to get a first reading of that at the December meeting. The executive committee was unable to set specific dates for 2023. I think there's a sense that there should be some regularity, some predictability to when these meetings occur for planning purposes. But even though there was no definite dates, there was agreement to have 4 meetings per year, one in late February, early March, another late May, early June, a third one late September or early October, and another in December. The State Emergency Medical Advisory Committee report, a number of motions were approved for which affect this region. So there's approval of the New York City Regional General Pain Management Protocol, also the New York City Procedural Sedation Protocol, Regional NYPSC protocols, and the New York City Regional Disarrhythmia Protocol. So that's good news. There's also approval of the collaborative protocol change as presented, and approval of adoption of the American College of Surgeons Trauma Triage Guidelines for 2023 for New York State. They will be effective January 1st, 2023. There's approval for bringing the New York State Advanced CP protocols in line with the National EMS Education Standards, which will also be effective in January 1st, 2023. There was approval of collaborative protocol change for pediatrics and adolescents. There was approval of the addition of taxamic acid and oxybenzone 0.05% to the New York State EMS formula. New York State accepted CMAC recommendations to have a state EMS medical director. DOH has sent a job description to the civil service to create a more formal job description that we approve of them, and also work on the job title prerequisites. It can be a part-time position, likely 24 hours a week, and we work on protocol reviews, assistant city EMS council, and working with the Bureau of EMS. They involve themselves with data research, the subject matter expert to EMS agencies and regions. EMS hospital wait times and conversion also discussed. It's as much a problem upstate as it is downstate, which is interesting to me. Drug shortages in policy statement 1304, ultimate medications formulated for pre-hospital drug shortages was discussed. Helicopter blood transport, this is a discussion that seems to be going on for a very, very long time. Helicopter blood transport and transfusions waiting DOH to develop regulations that SEMSCO and CMAC can vote on as per the legislative request. Telehealth, telemedicine, and hospital setting is changing, as we know. So there was a question of the role of the regions and the state in monitoring quality such programs. It was felt that the telehealth policy, that local REMAC REMSCO should have a policy in place prior to the nation moving forward with this. It can now be something that we discussed at the December meeting. There's also a protocol implementation field decided by SEMSCO CMAC a few years ago. This was to be done annually. This was reaffirmed. Statewide versus collaborative protocols, and merging them was also discussed will be explored by a work group. And that's the main items. Education training. Of course, the renewals are going out, half for getting a short term, the other half for getting a long term form. New regional faculty training program is coming out at the end of the year on the learning management system, and all current faculty will go through it. There was concern for New York State DOH EMS appointed regional faculty with no criteria for training program. It does not allow REMSCO input. That's something maybe we could discuss when I get to the end of this report. Also, certified lab inspector courses will be conducted partially online, and the other half to be done locally by course sponsors. The state staff were advised that this Louis REMSCO's for evaluating CLIs really removes the quality gatekeepers from the selection process, and that allowing course sponsors to evaluate, train their own employees may result in some state in training. So again, area of concern. Also, the EMS policy statement 22-11, digital electronic provider certification cards through the health commerce systems live. Getting an electronic card is voluntary upon the agency and the individual. Getting the process 22/11 must be followed. Actually, the agencies can verify certification dates, but cannot print out the individual's card. Only the individual can print it themselves. And the only individual can the same is true for the instructor cards that can only be printed by the individual.
right? And the last thing I was mentioned, the legislative committee, something that we took up over the summer, committee completed work on its task to prepare comments on Part F of the governor's executive budget proposals. We actually submitted our recommendations, okay, so what that should look like. Okay, it was presented as a second motion, okay, the SEMSCO formally accepted the former Part F updated document and vote EMS systems and legislation for further action. Okay, these recommendations we sent to UH and give our opinions in writing, okay, where they stand, okay, on Article 30.
Thank you. Yes, you can.
I just want to let everyone here know, I'm going to also repeat it at REMSCO. All the committees on SEMSCO and CMAC, all the subcommittees, you do not have to be a member of SEMSCO or CMAC to participate on the subcommittees. And we need more people from New York City to attend these meetings and be vocal. I actually received permission from my board to be able to bring up somebody, our training and education chair, Maureen Lax, coming up to Albany to sit on that training and education committee, whether as a member or not. So if you want any information on when these meetings meet, or if you want to, I'll send out a list of all the subcommittees. And if you let me know what you want to sit on, I can send letters to the chairperson of SEMSCO and CMAC and make recommendations. They're pretty open to getting people on. Unfortunately, Systems Committee, which is going to be going over Article 30, is already full. But I'm still going to be sitting on that, and I hope other people will be going on it too. Yeah, Dr. Langsam is a sitting member. But we need to be vocal and we need to be present.
Yeah, as said, there's a lot of participation now, so we need more participation so that our participation isn't diluted out.
Yeah.
Like we need to be more of a presence.
It just would be helpful to put everyone aware of all the different committees up there, and maybe.
Yeah, that's what I just said. I'm going to send out. Yeah, we had spoken before the meeting, so I just repeated that. I'll send out a list of all the different committees and their chair people, and just let me know what you want to formally be assigned to. Can't promise you will be, but it doesn't mean you cannot attend those meetings.
All meetings are open to the public, so anybody can attend. Drag yourself up to Troy, New York, very nicely. Nothing to do there.
SEMSCO members are supposed to participate on 2 subcommittees.
You can go up there anyway. See, Uncle Sam was born in Troy, New York. That's all.
Yes. Thank you for that update. Any questions on the CMAC update? Okay. So just to wrap up, there's I don't think there's any unfinished business. But
there's a big question about the.
Oh, that's going to be new, right? So the new business is the big elephant in the room. Now that we have all these protocols that are not going to CMAC, what do we want to do in terms of implementation? So that I was leaving that for last because I'm figuring that nothing else is going to get done after this. Any opinions, thoughts, comments? Anyone? Just I'm not sure if the video has been shot yet for the procedure station. So I'm training in that yet. So I don't know if you want to reach
Yes,
out.
all I was going to say is just to summarize, so there are 3 protocols that were approved in September, including the protocol that was discussed today. So it's we're talking about the severe nausea, vomiting / abdominal pain protocol that was approved in September, as well as the changes that were made to the general pain management protocol that was discussed in September. And then today, the procedural sedation protocol. So those are the 3 protocols that we're talking about that we want to be included for the 2023 rollout.
I mean, we have to speak to the Training and Education Committee.
No, I was going to say, I mean, in addition to whether those are live, it's the date that these are going to go live. Because even for the current protocols that we had slated for January 1st, we haven't, once we get the finalized version, obviously there can't be any training besides a directive that goes out at this point. If we're still going to look at January.
Okay. Well, what are the thoughts around the room? Okay, so the current January 1st protocol rollout probably can't go January 1st. What is the earliest that would be able to go out?
So again, I think most of the changes can be done in the directive. So if that's the case and there's no module or in-person training required.
Is there any procurement issues? I'm sorry, are there any procurement issues? New medications?
No, I don't believe so.
Okay, so if there, I mean, again, if it's just we're talking about a directive to send out, then January 1st is still a possible implementation date, correct? Okay, so do we think that that is appropriate? We can roll these in. I mean, unless training and ed has videos already done and we'd have to redo everything and that would be a problem.
That's kind of my concern.
Yeah.
All right, so we'll have to find that out. But if that's not the issue, let's put that on the side for a second. If that's not the issue, can we make January 1st?
Even if January 1st, we still need the final versions of all the protocols in the next week or so to prepare.
Right. But again, I don't think that everything has been approved now. Nothing is going beyond this. I think to get it by the end of the week is not undoable. Not undoable, is that right? No. Is doable. Is doable. That's better. Yeah, sorry for my double negativing. Sorry about that. But it is doable. So we can definitely get it all out to the region by the end of the week or so. The question is, from a training perspective, is there work that needs to be redone? In which case that would involve extending and delaying the implementation.
I think fire department could do it by January 1st if we get that final version.
Okay, so I think the real question is, what have we done in terms
Are
of?
we talking about the rescue protocol?
No.
Well, the rescue protocols, again, that's going to be for the rescue medics. You can figure out when that is from an operational perspective. I don't know if that changes for anybody else, but. So I think January 1st still sounds good as long as training and ed doesn't have to go back and redo a lot of things, correct?
Yeah, I mean, it's my impression that, I was away this past week, but it's my impression that they recorded the bulk of the videos, if not all of them already.
So let's
As long as
figure.
we get the final version, we just need that lead time, put it into our version.
Yeah.
It's almost like our CME journals, we always have the deadline. We can never get it out on time because we don't get the final version until 2-3 weeks into when it was due.
Right.
And it's always delayed for us.
Okay, so I think that this is a question that we have to ask the T&E, figure out where they're up to in terms of the training package, and if these additional protocols would delay the rollout to the LMS. Is that fair? Is that a fair assessment?
Yes.
Okay, so saying that right now, it sounds like January 1st still works unless there's a problem with T&E. So let's address that with T&E, and if they're okay, then January 1 will work. If not, we'll have to figure out where we extend to. David.
So can we make a decision here that we request the executive committee to review this and make a decision to implement rather than waiting any further?
No, I think that as of right now, the date will be January 1, unless there is a delay for some reason that we don't know of yet. And if that happens, then we will reach out to the committee via email and communicate that there will need to be a delay based on where T&E is. And it's not T&E's fault. I mean, we waited to the last second to give them all everything they need. But I think that what we're saying here is that January 1 will work as long as T&E can get the videos and everything done by then. Does everybody agree with that? Okay.
Had a lot of conversations with Morty about this as well over the past few months. Two things I just want to bring up. I know Morty's not here, but he really needs physician involvement at the training and ed committee. I've helped him out, but it has a little bit of compliance issues with credentialing committee. So if you're interested in this education piece, please help Morty out. It does go a long way. As it's the end of the year, there's been a lot of CME sent out to Morty and to myself for requests. Various hospital agencies, looking to make their requirements for their annual requirements. I did say it openly. I bring it up here as well. There was one of the EMS discussions was led by a vascular surgery fellow. In the era of board certification, this is an abomination. And there's several of our fellowship grads who can't find jobs in the area. And if hospitals are out there using vascular surgery fellows to teach the current standards of practice in EMS, which many of us are board certified in, again, it's an abomination. A lot of these are being declined, which is actually to the detriment of our providers. And I think it would be better to have integrated EMS physicians in these symposia so that the medicine is being taught the right way, as opposed to a trainee.
Good point. Thank you.
Can I just have one thing to raise comments about the REMSCO subcommittees? There is a new subcommittee, the DEI subcommittee, needs members. So if you have an interest in diversity, equity, inclusion, please Because I realize I'm the face of diversity here, but we need more members.
Okay, Glenn.
I'm sorry, I know we all want to get out of here, but just a thing of new business. Over the last several weeks, we got a rash of complaints from hospitals saying that when they requested diversion, they were denied. So they're saying, well, so this is nothing new. For the last 15 years, we used to send by mail every year, once a year, to the CEOs of the 911 facilities to say, hey, here's a list of CCC codes that you're accepting and those that you're not. We want to make sure that that's up to date. And then also on that list is a list of titles that can authorize a diversion. So that's nothing new. Everyone thinks it's new now because Ops has told FDOC diversion does to stick to that list. Not a name, because we know the turnaround time, turnover is every other month, right? So if we did a name, that would never work. So they're adhering to the titles now. So somebody calling who's not on the list is not going to be able to get that authorization for the diversion. Now, that resulted 15 years ago or so because we had a complaint from administration of a hospital saying, wait, why did you put us on diversion? Oh, the charge nurse said this, and that, or the attending. And the administration said they're not authorized to do it. So we had to kind of have a system. So since this year, we've gone electronic. So twice a year now it goes out. Much better, because we used to get some of these unopened letters addressed to the CEO 2 months later coming back saying, this person's no longer here. Why didn't you just forward to the new CEO? But they're delayed. So that's something that I think has straightened out a little bit, where hospitals now have given us updated lists of types. The other issue is diversion. We're having huge problems with diversion, right? We're tackling right now EDP diversion, right? We do 160,000 calls system-wide for EDPs per year, okay? And the diversion requests, so many facilities just are not accepting EDP. So, 40% of the EMS systems in the country, they don't honor, there's no such thing as a diversion, right? We try to honor it as a courtesy. We'll never take a gunshot wound to the head to the local ED, short of being a cardiac arrest. We're going to take them to the trauma center. That's always going to happen. And even these systems, Boston being the large EMS system near us, who say that they say we don't have diversion. And I say that yes, because if the hospital blows up, you're going to divert. So that blanket statement of we don't divert is not really true, but they just don't do it routine. Okay. We're getting to the point where we're looking at it now where we're also potentially having to go to not having diversion then. It's a courtesy. Try to do the best we can. EDPs we're looking at particularly because we have had several cases where EDP diversion in Manhattan, the unit now goes to Central Brooklyn as the next available. We just can't sustain it. And so we try to look at the numbers. We're meeting with Greater New York Hospital. We're meeting with some of the psychiatric facilities. And the numbers we've shown are CPAPs. There's one CPAP that out of 365 days, they're on diversion 241 days. You can't sustain that. So we're almost getting to the point of, we're looking at EDPs now, but ultimately, we may have to follow the state rules and say, as a 911 receiving facility, whether you walk in or you come in by ambulance, you have to handle that patient. If you think they need to go somewhere else, that's your business, right? We're getting to that point. So if you get calls from your hospital administration, that's kind of where we are now. And we're trying to avoid eliminating it, but we're getting to a point of being lost. We are averaging usually 4,200 calls per day. Recently, it's been 4,500 to 4,600 calls per day consistently. You're seeing it, right? Short-staffed everywhere. It's getting to become a huge problem. So in case you get questions, that's what we're doing.
I have a question. So what can we do to help? What can this body do to help? Because I gotta tell you, they have no problem calling me at night. Yeah. And I pick up the phone in the middle of the night. It's a problem. Behavioral health is a huge issue in the city.
Not only in the city, in the state.
And it's not going away.
It's a state, the country. So
it's a state.
It's a resource utilization issue. There's so many components. We just, I wish we knew what the solution was. That's the really big part of it.
More beds.
More CPAPs would definitely help. I know. That's all we have. All right. Thank you for that, Glenn, but I'll entertain a motion.
Motion to adjourn.
So moved. Second. Okay. Thank you, everybody.
We need more drugs.